sounded really good. How many were here for the last speaker? I have an issue with what he had to say at one point, and he had made reference to teleportation being something science fiction-y in the future and all that. I want any of you interested in that to Google Niels Bohr Institute in Copenhagen, because on the subatomic level, they have already transported photons using string theory and entanglement theory. I'm just saying. So just a reference there, just to put that on your Google later on. All right. Let's start with this presentation now. My name is Brian Coltharp. I've been with Health Resources of Arkansas up in north central Arkansas for, since 2001. I got there just after the 9/11 attacks. I was hired as a mental health paraprofessional going out doing home visits. And probably the third or fourth week I was there, I went to a home visit, knocked on the door, and found an individual with his shotgun pointed at me hiding underneath the kitchen table. He let me in. I don't know why, but he let me in and then pointed to the TV in the living room and let me know that 9/11 was on, and that was how I was introduced to what had happened in New York on 9/11. So it makes it a real easy reference for me to remember when I got hired at Health Resources of Arkansas. So and I've had wonderful adventures out in the hills of Arkansas, just like that, for quite some time. But after a very short amount of time doing home visits, the company decided that I would work out better in some of the other areas as a troubleshooter based on some of my background. Now, I'm not the sharpest tool in the shed, but I'm also not the dumbest. But the most important thing I want to bring out in the presentation today is that I have no formal technology, no formal IT training whatsoever. I've not been to a college class for IT. I haven't been to, I'm not Microsoft certified, none of that. I'm a guy who was a case manager who got leaned into the technology field and was one day told, we need to do telemedicine. We need a solution for a problem in our upper north central counties. Figure it out. And from 1 month to the next, I figured it out. And I figure if I can do it, anybody can do it, Microsoft certified or not. So here's my story. We're, again, in 22 counties. The southeast 6 counties are substance abuse only. The other northern 15 are mental health, everything from mental health, substance abuse. We see children. It is a community mental health center in each one of those counties. Some of these counties, like Newton, has a little town called Jasper of 120 people, and we have a clinic in there. And we have a video conferencing unit, and there's a child psychiatrist, one of only a dozen in the state, I think. We may have less than, 2 dozen child psychiatrists in the entire state. We have a child psychiatrist who will see children via telemedicine in Jasper, population 126. So if we can do that, anybody else can do that. And that's if you take away nothing else from my presentation today, it's a little town, an IT person with very little training, with zero budget initially, did this and did it wrong and still made it work. So for those of you that are not IT, who are not do not have a technical background, this is a perfect time. I'm going to give you about a minute and a half to check your emails, Google, Facebook, whatever you want, because I'm going to tell you a little bit about our IT network, the way it's set up right now. We have a 22-point hub and spokes MPLS network. We have 19 1.5 megabyte T1 circuits. We have one 4.5 T1 circuit, which is really 3 bonded T1s. We have one 25 meg fiber optic circuit that's at our hub. We have one business DSL, 12 Polycom units, 14 Tandberg units, one video border proxy, a scheduling bridge, which is an RMX 1000, and 5 blade terminal servers, and 2 PRIs, which are public relay interfaces. That's our circuit. That's our entire network in 22 counties. We tie them all together on an MPLS network. We have 350 phone extensions that are all 4-digit phone extensions that we pay no phone bill for outside of long distance, because everybody who talks to anybody within our agency does it over our network like voice over IP, and we pay nothing for it. This will become important later, but right now, just enjoy. Right now, the way we were set up back in 2005, we have, as you see the red dots up there, Melbourne, Ash Flat. The center dot is Batesville. We also had Mountain View over there. Fairly small towns, rural facilities. You see the big green dots, Conway, Little Rock, Jonesboro. As you can imagine, to get a physician from Conway, Little Rock, or Jonesboro to go to, say, Newport, which is the blue dot all the way over on the right, not so difficult. The big red dot down in the bottom center, which is Searcy, get folks from Little Rock or Jacksonville, not too difficult. Try to get a doctor to drive all the way up to Ash Flat or to Melbourne or to Mountain View to see clients, we'd be paying through the nose. And that's what we did for a long time. There were no other options. Our company started in 1969, and we had to have medical services in all of those rural counties all of that time. And we either contracted with a local doctor who was comfortable enough with doing psychopharm, or we would take our own psychopharm doctors from the bigger facilities and travel them out there 2-3 times a week. We paid for the face time, or what they call that windshield time. We paid for the windshield time of that doctor, and then we paid for the doctor to see the clients. As you can imagine, the more they had to travel to get out there, the less people they saw while they were there, and the less revenue they made on both ends. So this is what we ended up with. We ended up with folks driving an hour and a half, hour and 45 minutes, up to 2 hours per trip to go see clients in these facilities. And I don't know how y'all's doctors are, but ours said, I'm going to work 8 to 5, 9 to 5 or 8 to 5 with a lunch, 9 to 5 without, and that's it, 8 hours a day. So if it takes me 2 hours to get to the clinic and 2 hours to get home, how many hours am I actually going to see people there? 4 hours. So I've lost 4 hours of revenue, 4 hours of client time, 4 hours of them actually being able to help people, and I paid them 4 hours to listen to their iPod on the way up. Well, in 2005, through a couple of 2 or 3 different situations, the 3 or 4 doctors that we had that were doing all of that traveling, within a few weeks of each other, all quit. And I say quit in general terms. One of them decided to leave and go to a larger medical facility. Another one moved up to finally see his wife in New York, who he hadn't seen in several years. Another one went to expand his private practice over near Newport. And so they all just basically gave notice, not knowing what the others were doing. Just through attrition, they all dropped out at the same time. So now we have all of those facilities that need to be covered, and we have one doctor down in Searcy who's covering Searcy. And we had to figure out very quickly how to do it. While I was putting together a telehealth network for these 5 or 6 counties, the clinical director was trying to hire more doctors, because we had half of our folks saying, we need to do what we've always done, and we need to hire more doctors. And then you had our CEO pointing to me saying, you're the troubleshooter. You're the guy that's supposed to fix things. Figure out a way to make this work. And no, you don't have a budget. Figure it out at cost or less. If you make money, I might give you a raise. Okay. So here's what I presented to him the first time I came forward with this. I'm going to lease 5 telemed units. They're about $6,000 or $7,000 a piece. We're going to get a 6-year lease, because that's as far out as I could stretch that sucker. We're going to get a 6-year lease on these telemed units. We're going to install T1 lines. The T1 lines were $550 a piece. Scared the pants off of him. $600 worth of leases for the telemed units per month, for a total of $3,300, $3,350 new to his funds, to his accounts receivable. He was going, or accounts payable. He was going to have to pay almost $3,400 a month for this network to get put up in these 5 counties. He about lost his gourd. But then I went to the next step and said, look what it's costing you to do it the old way. You have 4 trips, a doctor going 4 times to Melbourne, that's 16 hours a month. Mountain View, 8 trips. Ash Flat, 8 trips. Batesville, 16 trips, for a total of 96 hours a month of medical time that you're losing. And he went, wow, that's like $4,800 a month. And I said, no, it's not. It's like more than that, because and this is just the assumption. Okay, we all know that doctors don't get paid $50 an hour, and we know that at least via Medicaid, they don't make $50 an hour in revenue. Those numbers are quite higher, but these are the very conservative numbers that I put forward to this CEO, so I would have no argument whatsoever. I cut these numbers almost, well, a little bit more than in half, and said at the bare minimum, no argument whatsoever, $50 an hour for your doctor, $50 an hour for lost revenue. You're now looking at almost $10,000 a month that you're losing by sending a doctor up there on the road the way you used to. Now, isn't it worth $3,400 a month to change that? And so we went forward. This is the thing that I had to explain to that CEO. I had to get across to him. We don't want to pay for free knowledge. We don't want to have to pay for free information. I had to explain that to him because he wanted to know, how am I going to make all of this happen without a budget? How am I going to have it's one thing to put together a cute little spreadsheet like that and say, here's what we can do. And he, being the smart businessman, said, you're going to have to hire a consultant. You're going to have to hire specialists. You're going to have to contract with people to come in and install stuff. And I had to explain to him that the internet, even back in 2005, the internet was filled with free information, and it still is. Here's some of the free information that's available on the internet right now. Tandberg setup guides, Polycom setup guides, bridge scheduling setup guides, room setup and implementation guides, telemedicine solutions. These are very, very close to the same guides that I used back in 2005. It's free information that's on the internet. Most of this stuff, you could Google those headlines right there, and you will get 4 or 5, 6 different options. Some of the stuff, if you're not afraid to go to the university websites, like some of this stuff here is, where was it? The state of Maine, the third one down. The state of Maine set up a video conferencing network, and I'm borrowing their bridge scheduler because they were happy enough to put it on the internet and say, hey, anybody that wants to know how to use our scheduling bridge, here it is. Now, they meant it for the people in Maine who were going to use their scheduling bridge. But guess what? It's a Polycom scheduling bridge. It's the same kind I used. So go ahead. Here's the 3 things that you need to set up a network. And they're very simple. The first one, the top one, is a router. Now, they come in all different shapes and sizes, but your internet service provider or your phone company is going to provide you with a router when you say, I want a T1 line or I want a DSL, business DSL line. They will show up and they will bring a router and they will assign you an IP address on their network. Now, we're talking public network right here. The second thing you're going to need is a video border proxy if you're going to want to have a private network. Video border proxy is that little device down the bottom. It costs about $1,200, and it will save your IT folks hundreds of hours trying to figure out how to make your network secure and be able to talk to everybody else in the outside world. The third thing is a switch. Those things are as simple as a Netgear switch, a little blue box that you can buy at Walmart for $40 or $50, clear up to a Cisco switch that's a gigabit, $600 or $700, and everything in between. But these are the 3 basic devices that you need. It isn't magic. You have 3 devices, you hook them up, you put them onto an IP address that's with your from your internet service provider, and bam, you can plug a telemed unit into it, you assign it an IP address, and suddenly you're able to talk to everybody in the world, and they're able to talk to you. Now, it gets more detailed than that when you want to talk secure, and then LANs versus WANs and all that, but the basic concept, you have a clinic in the middle of nowhere, and you want to get them onto telemed, that's it. And that's the short version. Here's the equipment that is daunting. It's on the very far right. If any of you are dealing with UAMS, you've got the BTOP or the E-Link grants. They show up with a huge cart like that. It has a video conferencing unit, has the monitor, the cameras, all comes together. When I first started, if you look at the top center, that thing that looks like something from War of the Worlds, those are the 5 telemed units that we had. Did not have it on a flat screen monitor, had large 36-inch monitors, 36-inch televisions that were too big to fit on this table here. It would have, the TV would have easily stuck out the front end and out the back in 2005. That's what we had. Came on carts as big as that table. rolled them from room to room. Huge equipment. We have got it. Things have become so much better now. But back in the old days, that's what we started with. It's the only options we knew about, so that's what we did. Now, we did do some things right. The first thing is we collaborated with our telecom installer, which was Heritage Communication right here in Little Rock, and telephone sales reps, AT&T, and our IT staff. We got them all together and said, this is what we want to do, and then we sat back and listened to them argue at each other for about 15 minutes. And then brought them all back together and said, this is still what we want to do. The second thing we did is we researched the rules and regs for reimbursement. This was very important for my boss because he wanted to make sure that if we were going to do telemed with Medicaid or with Medicare or some other insurance agency, that we could get paid for doing it. Because the only thing that could have made this thing fall apart is to be providing free services that nobody's willing to pay for. Back in 2005, one of our payers had actually had on their books that they would provide or would allow for telemed services, reimbursement for video conferencing, telemed services for everything from child therapy right on up through the roof. And we're like, woohoo! So we got our stuff set up. We billed them. First week went by, no reimbursement. We billed them again, came back again, still no reimbursement. We started making phone calls. We started chatting with people. Guess what we found out? The people who set up that policy never expected anybody to use telemed. They didn't even have a service code for it. They didn't know how to handle it. And so it took us 2 or 3 months for one particular agency before they could get their act together and start reimbursing us for telemed services because they had it on their books but didn't really know what to do with it. We started out slowly. Like I said, we have over 20 telemed units right now. Some of it from UAMS, which are Tandberg. Some of them are Polycom. We have a lot now. We have at least one telemed unit in every one of our 22 sites. But we started out with 5. Started out small, got our act together, made sure it was working, and then got 7 more after that and a few more after that, and now worked our way up. We began with the medical staff. I can't emphasize this more. Every agency, every program, every corporation has a hierarchy of folks. And if the top of your food chain is the director of nursing, then start with her. If the top of your food chain is the psychiatrist, in our case, our child psychiatrist rules the roost. And so we wanted to make sure that psychiatrist was on board with it first. We'll give him the best and the biggest and let him work with it. Once he had his stamp of approval on it, he didn't have any problem telling all of the clinicians and the case managers and anybody else down the line that this is how this is the direction this bus is going. You can hop on board. We had originally started out and said, well, let's just have the therapist do it because we don't want the psychiatrist to get run off. It's all we got left, But if we offend the doctor and he doesn't want to do this, then we look bad on both sides. So let's get a couple of clinicians over here and a couple of clinicians over there. And what we found out with that is it didn't do any good at all until somebody up top said it was good. What we found was the therapist would, if we had this therapist over here and they liked telemed and somebody else over here didn't, they would say, well, that therapist doesn't know what they're talking about. Well, therapists can't really do that to a psychiatrist because like the psychiatrist trumps therapists. So we had a therapist, and we did have this happen. The therapist said, well, I don't think he knows what he's talking about. That psychiatrist didn't have any problem at all once he heard that rumor of spreading out an email to the entire company saying, let me explain to you what I'm talking about. And then all the other therapists said, well, maybe we should give it a try. Start at the top and work your way down. I can't tell you how much time and energy that saved us. Where are we at? We learned how to configure the equipment during the installation process. You're going to have somebody in your company, even if you contract somebody else to come and install all the equipment, somebody needs to know how to fix it when it's broke. And I don't mean just when the remote control doesn't work, but little things like being able to plug it back into the network, being able to find that IP address again, things like that. We have storms up in north central Arkansas. I'm sure the rest of you don't. But if a lot of our telemed units, if the lightning strikes and the power goes out in the building and the telemed unit is in and connected with somebody else at the time, there's a 70-30 chance that when that telemed unit comes back on, it will have lost its original IP address. Somebody needs to know how to type that booger back in. So there's another thing that saved us a lot of trouble was minimal transition time. Once the doctor was on board, we didn't give people a lot of options. We didn't let them say, well, I think I might try it, I think I won't. For the people, the LCSWs, the LMSWs that we were going to have use it, we set them up and said, here you go. This is what we're going to do. Now do it. If you give them an option, I've run through this with EMRs. We initiated or implemented EMRs. We went from transition from paper to electronic. And if you give them the option, let them get used to it at their own pace, you will have folks that will retire not yet used to it. And if anybody's ever experienced that, there's just a little bit of wisdom there. We used the largest monitors we could afford. That's important when you're dealing with clinical services. I've been to other agencies where folks have gone cheap, and I'll talk about that here in a minute. And they started out their telemed services in a Skype type version, and that doesn't help the clients, the patients. It doesn't help the medical staff. It's not good all the way around. You've got to invest in at the very least a large monitor and bandwidth that'll keep the jitter down and keep quality video. We continue to seek out new resources, new grant opportunities, and new connections. I did start out with no budget. That's the truth. But very shortly after that, we found that these original 5, they didn't last long. A year and a half, 2 years, and they start dropping, and then you have to replace them. And that's where grants and additional funding worked out for us. Use class of service to share the line. Jasper is a great example. Population 120, we have 4 or 5 clinicians that go down there on a regular basis. That is not a fully functioning, fully absorbed clinic. We don't have people lined up outside the doors at 9 a.m. when that clinic opens. Okay? So what we ended up doing to save money was we had one T1 line, 1.5 megabyte circuit that's installed at the Jasper Clinic. We use class of service, which is a techie term, to split that line up. So now we use 384 of that line for telemedicine. Another 384 we use for the phone services, for the voice over IP phone service. Another 384, actually most of the rest of that 768 is for the computers, for the electronic medical records, for the internet service, for them to be able to get on and do Facebook when they really ought to be looking up something clinical. So we split that line up in 4 pieces, and we used what's called class of service and said, if you're on the video call, it takes precedence, and it is going to steal 384 kilobytes of that service, of that line, of that bandwidth, and it is going to take precedence over everything else. Let me go to, I've rearranged these slides a little bit. One of the slides I've got says, don't go cheap on your bandwidth. Bare minimum, if you're going to use it for other things, use at least 1.5 megs. Use a T1 line. Now you can, if all you're going to do is video conferencing and that telemed is all by itself and that's all it's going to be used for, then you can go ahead and get your 384 out of a business DSL or something like that. But if you're going to share the bandwidth, be careful to not go with a fractional T1. And I'll talk about that a little bit later. What we did right, we prepared the sites. Lighting, color schemes, monitor sizes, furniture, privacy. A lot of our rooms were already prepared for video conferencing. It doesn't take much. You got to be careful with things like paint, wall finishes, wall colors, furnishings. Use muted tones. Don't use high gloss paint. Try not to take the room that has the full picture window and decide that you're going to use that for video conferencing. An interior room works much better with appropriate lighting. Don't use too much direct light. You can read this. This is basic stuff for setting up a video conferencing room. And again, you can go to websites and see a lot of this information. I pulled most of this off of a website which I used when I first started. The ATA website, Learn Telehealth, has got some good stuff. These are all basic ideas here. Lighting, sound, furniture placement. I can't help but overemphasize the furniture that you're going to use to put the patient in if you're going to do a half-hour or 1-hour clinical mental health type setting. If you're going to put a patient into a chair, make it one of these style, nice, four-legged, comfortable cushion chair with a couple of armrests that are lower setting. Our psychiatrist loses his mind when you have a client who sits in a rolly chair and starts spinning and swiveling and tilting and kicking his feet up onto the chair. And believe it or not, here's the emphasis. No tilting, no swiveling, no reclining. I feel like a kindergarten teacher. No rolling, no swinging. And you say no swinging? Yes, I've been to telemed rooms where there are couches that the client sinks into and his knees are up around his shoulders. What kind of clinical services are you going to be able to extract? What kind of body language, spontaneous goosebumps, tears, knee jerking are you going to get out of a client like that? A hammock chair hanging from the ceiling. There is a therapist, LCSW, Mountain Home. I'm not going to give you any more details than that. Not with my agency. I did a little consulting. I went into his room where he wanted me to set up his telemed room, and he had a hammock chair hanging from the ceiling next to his desk. The clients, the patients, sit in the hammock chair, and it gives them a feeling of centeredness while he speaks to them and shares, and they coerce back and forth, whatever. No. I just tell him no. You need to get rid of the hanging chair. We can't have a hammock chair. The psychiatrist in Little Rock is not going to appreciate your hammock chair when he tries to do a child med eval or something like that. It's not a good idea. No sitting on the floor. Basic idea, nice four-legged chair, clear, bright, eye-level, unobstructed view of the entire body, toes up. If they're tapping their feet, psychiatrist is going to want to see it. If they're fidgeting their hands, and one of the things that I would also suggest is if you're looking at telemed equipment, try to go a step up on the models with those that don't look like the old cameras that zoom around like this, but the ones that just have the tubes on top, and when you focus and when you zoom, the tube stays where it should, and the mechanisms inside the camera move around. Our child psychiatrist loves that because he can zoom in on the guy's right hand or the kid's right hand and look at that and see that thing just, twitching or doing whatever. He said, if I do that in a regular setting, face to face, I glance down at that hand and spend too much time looking at it, the kid or the patient recognizes it and does one of these numbers. He said, I can take that camera, zoom into that hand and count the number of hairs on the first knuckle and watch that hand, and the patient has no idea where I'm looking from the screen. That comes up to another point, is the picture-in-picture. The little mini picture. Some of the patients love that. Some of the patients hate it. Teach your staff to ask them and find out. If the staff member that's in with the patient notices that they're spending more time staring at themselves in the TV than they are interacting with the psychiatrist, click that thing off and take note of it in the chart and don't have it on next time. Just little things. So we prepare the sites. Now you prepare the staff. Camera functions, image size, volume control, confidence, and normalization. You want to be able to you want to talk to your staff and make sure they understand that this is not some freaky outer space sci-fi version of clinical services. The nurse or the APN or the case manager, whatever staff member you have that's in the room with the patient on telemed needs to make it as normal of an event as possible. And one of the ways we do that, I'm getting ahead of myself. You want to make sure that they're fully trained. When I talked about volume control, camera functions, etc., that all circles around this remote control. And we need to be very careful that the staff understand how to use the remote control. I tried, and this was something I did wrong. I took a card like this, got it laminated, and put it with each one of the telemed units, gave a 5-minute instructional on how to use it, and then let them go. 6 months later, I was surprised. It was almost 9 months later. I was surprised that one of our clinical staff said, "Did you know?" Because they learned this yesterday. I can mute the microphone on the far side so they can't hear what I'm saying when my phone rings. I said, "Yeah, that's really cool." what I wanted to say was, I told you that 9 months ago during my 5-minute, this is not a good way to teach them. You need to be able to sit down with your staff and have them prove to you that they know what they're doing. A couple of the websites that you can Google Tandberg or Polycom or LiveView, whatever units you're using. Google instructions, Polycom remote control instructions, and what you'll find is agencies all over the United States who have put very detailed instructions, trainings, check boxes. Make sure your staff know how to zoom and pan and tilt and mute on and mute off. And they have a checklist of things that your staff need to know how to do before you walk away from that telemed unit for the first time. And these things are, again, free information. It's all out there on the internet. You can just find it, just Google it. If you think that that's scary, because after I looked at it, I went back the other day without having that techie background attitude, and I looked at it and went, man, that's kind of daunting. But thank goodness our Polycom ones are better. Yeah. So once I was informed of it, I adjusted accordingly, and we started doing a little bit better on the training side. So we prepared the sites, the staff, prepared the patients. A lot of folks miss this. Now, you get the consent forms down, and you send the notices out and tell them that it's coming. But what else? I mean, this is a brand new event for a patient. He or she's going to see themselves and a doctor in another city on a television. And that's going to be called medical services, or that's going to be called therapy. They need some normalization. One of the things, and I love our LCSWs, one of our LCSWs taught me a better way to work with the patients. He said, give it to them like it's a kitchen window. And of course me, I'm not as country as I look. I was born and raised in Seattle and moved down here long after adulthood. I looked at him and I said, I don't understand what you're saying. And he said, well, you know how you got the apple pie on the kitchen windowsill and it's cooling, and the neighbor comes over to smell the apple pie and chats with you through the window, the kitchen window. Like talking to your neighbor through a kitchen window. And I went, does that really work? Does that analogy work with you and the patients? And everybody in Mountain Home, Arkansas gets it. I didn't get it, but everybody there gets it. So we use the kitchen, I use the kitchen window effect. When we have this big 36-inch monitor, we want the psychiatrist to look like he's staring through the kitchen window 5 feet away from the patient. Head and shoulders about that size. Make sure the volume control is the same as the volume. Make sure that the lighting on him is the same as the lighting in the room, so that in about 30 seconds of chatting, the patient gets the feeling subconsciously that they're talking to somebody through a window, like he's just got his hands on the windowsill. And if you can do that, that normalizes the patient to the session. Wow, that never occurred to me, and I thought I was a pretty whippy guy. So this has become the cornerstone of our normalization technique for patients, and it works really well. Doesn't work with every patient, and that's another thing. When you get ready to prepare the patients, you need to screen them ahead of time, and you need to make sure that your strongly schizophrenic patients, highly schizophrenic patients who are in day treatment because they can't function outside of day treatment services, who see and hear things that aren't there. You don't want them on a 384 DSL line with a doctor on the other end that's voice is not matching up with his lips and he's jittering all over the screen. That's trouble waiting to happen. So you need to screen the patients and make sure that at least at the beginning that the patients that you're putting on telemed are stable, who regularly come in for their visits, have a strong connection with the psychiatrist that they've seen in person before they start seeing him on the TV for the first time, and then work your way forward from there. We avoided the desire to go cheap. We didn't use Skype or webcams. We didn't use small monitors or laptops. We used nurses, not staff. Now, Medicaid, I love Medicaid's policy. Right now, unless it's changed, Medicaid policy for RSPMI is that a staff member must be in the room, and it doesn't specifically say a clinically experienced, blah, 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 a staff member. When that was first brought up in 2005, one of the folks in our agency said, oh, excellent, so we can stick the secretary in there while there's nobody else, in the clinic. We can put the secretary in there and we can save us a little bit of money. No, and we forced that issue from the very beginning. Have a clinical staff member, a nurse, at the very least, a mental health paraprofessional who can see the signs of a person who's getting agitated and recognize, issues. The guy's about ready to throw the chair through the television. Case manager may be able to recognize those signs. A secretary's not. So we didn't go cheap. We had options for the uncomfortable clients. Unfortunately, the options back there were, well, we'll bring a psychiatrist out here once every month or once every 60 days. You can either drive to him or wait 60 days for him to come here or see him on telemed 3 times a week. So, we did have options, though. We didn't make it a complete cut and remove. We distinguished telemed billing from on-site billing, and that became important later on. We didn't realize how important that was. We scheduled it differently and made the billing differently because of our EMR and scheduling program. We wanted to make sure that we could distinguish a telemed visit from an on-site visit, and we had the billing to follow that. It wasn't too long after that everybody jumped on board with different codes for telemed services, and we realized, wow, had we done this the other way around, there'd have been a lot of confusion and a lot of, just a lot of frustration. And so we inadvertently distinguished telemed billing and telemed scheduling from on-site, and it worked out really well for us. So that was a lesson that we learned. We realized and tried to push this message out that it was enhancing our on-site services. It wasn't just replacing. The psychiatrist still came out every once in a while, not near as often. Psychiatrists didn't do everything over telemed. There are things that a psychiatrist or the clinicians, emergency services, those things, there are things that need to be done in person, and we weren't trying to just, replace the engineer with a computer. So that was important, and that was a strong message to put out. Things we did wrong. We didn't shop around. We didn't have a lot of time to. We didn't have grants that we could just pull out of left field. We didn't know a lot. We were in north central Arkansas, and our access to resources was, who do you know? Well, there's this guy I know in Little Rock and the internet, and that was it. And so we didn't have a lot of resources. We paid full price. We used a secondary vendor. The guys that helped us with our voice over IP phone systems purchased our telemed equipment for us, and they went through an authorized vendor. Because of that, we lost out on a lot of things. We didn't know that there were multi-point restrictions. We thought, all right, five telemed units, we can point them all at each other. We can have Dr. Madden or Dr. Brown down in Searcy, and he can talk to all 4 or 5 of them at the same time. No, it doesn't work like that. They have restrictions. You have extra licenses you have to get. Directory services. It took us forever to find out that there's a directory on the telemed unit, and you can pre-program them buggers. And all you have to do is go to contacts and click Searcy, and you don't have to remember that long IP address or the alias or any of that stuff. It just does it for you. Well, it took a little while, and that was HD versus standard definition. We got those great big boxes. The reason they were so big was those were high-definition TVs back in 2005. 36-inch high-definition TVs. Guess what kind of telemed units we got? We got what are called VSX 7000s from Polycom, not high-definition telemed units. It wasn't until 3 years later that we could afford the HDX 7000s and be able to use the high-definition screens that we had purchased 3 years earlier and hadn't had a chance to use. So these little things, anyway, you learn. We found out Polycom grant assistant programs, Tandberg grant assistant programs, authorized reps from Polycom, Tandberg, whatever service you use. The authorized reps have a wonderful time telling you about all this stuff and helping you get onto these grants, because if you can pay for the stuff, you'll buy more stuff. We didn't know that. We ended up paying $7,500 for our first HDX 7000 units, which were 3 years into our program. We could have done the QDXs for probably half that. We didn't know it. We now know. But anyway, it was still cost effective. If you look way back at slide 3, my original graph, still made money on it. So I didn't lose my job. Don't take bad advice. Now that's kind of a conundrum there, because you don't know you're getting bad advice until later on, right? But here's some bad advice that I got. The first thing was I had a telecom or a telemed coordinator from another state. I won't mention which state, but they're north of here. Said that we would not be able to connect to the outside world. We had our 5 telemed units in those rural counties on our service, on our circuit, and he told me flat out, you will not be able to connect those to Little Rock or to anywhere else outside your little circle unless you make public circuits out of them, and if you do that, then you're not HIPAA compliant, so no, you can't. Absolutely not. Those 5 will always be able to talk to each other, but no one else outside of that world ever. Well, we find out that's really not the case. We bought a video border proxy. Video border proxy is that cute little device that sits on the edge of your network and allows the traffic for video conferencing units to come in and out securely, and it only connects to the ones inside your network that you tell it to. So that's the security. That's some of that HIPAA compliance there. The video border proxy sits on that side. It's public video calls, and it does do it securely. Well, we didn't know about that for several years because I hadn't been involved in anything with video conferencing until I went to a conference in Chicago, and I heard them talking about it, and I went, wow, wait a minute, really? I wasn't smart enough at the conference to ask, how much does a video border proxy cost? Because I knew that our contracted IT staff in Little Rock would know, because this is stuff that they deal with all the time, right? So I leave that conference, I come back to Little Rock, I talk to them, and I say, we're needing to buy a video border proxy. And you know what he says? That's going to be about $85,000. Now, this is back when $85,000 would buy me my 5 terminal servers for the entire network. I was like, well, okay, so that's not going to happen. So we went at least another 6 months or a year without a border proxy because it was going to cost $85,000 for that little box. We contracted with the man for 30 hours, $105 an hour, $3,100, to have him tweak our ports, our port settings, and our gatekeeper and all that, or our gateway, in order to be able to securely make those kind of connections without a border proxy. 30 man-hours later, he was still not able to do it, and we're not sure today, still not sure, if our port settings ever made it back to the way they were originally set up, because he spent hours tweaking those things in all different directions. Never got it to work. Eventually, I start searching over the internet, and I find out that video border proxies are like $1,200. Now, you can get an $85,000 one. I'm sure UAMS's video border proxy or the group of them that they have are much more than $1,200 a piece. But for what we needed, $1,200. So we ended up getting that from somebody online. Our internet service provider, another great story. They said there were absolutely no programs available to reduce our internet costs. Not long, back into 2009, we were up to $16,000 a month for our 22 sites to have T1 lines at each one of those sites. And we were just paying that through the nose, just paying it every month because that's the cost of doing business. If you want a T1 line in 22 locations and a large 25 meg circuit at your host, this is what you got to do. So we paid $16,000 a month for quite some time, and then we came across this organization called USAC, Universal Service Administration Corporation. If you ever look at the bottom of your phone bill, everybody's phone bill, anybody in the world in America has a phone bill. Way down at the bottom it says Universal Service Fund, and they steal like $20 or $3, or depending on the size of your phone bill, they steal a small percentage of your phone bill, and everybody wonders, where does that money go? That Universal Service Fund is a huge multi-million-dollar fund, and for us, we see it over in Maine, but over in Maine, FCC manages that fund, and they have contracted that out to USAC, and USAC takes that money and helps give discounts, subsidies, to folks like schools, rural health community clinics, rural health mental health clinics, folks like that, for us, all we had to do was be a rural health clinic or mental health, community mental health center, and suddenly we've got almost 66% of our monthly bill being taken care of. Blew my mind. I did get a raise out of that. So we got all set up. I went through. We did the enormous amount of paperwork, and the first year that we were doing it, we made a small amount back, about 25%. And then we found out that there were agencies out there like Telequality and some other USAC service agencies whose only business is to set you up with video conference or to set you up with telecom services and help you get that 66% USAC funding. They were able to get us the largest eligible amount of funding available to us, which required a lot more paperwork than I was able to do, a lot more legalese than I knew about. We gave them a small bit for servicing us, and we get the rest. We've now cut our Telequality bill or our telecom bill from $16,000 down to about $7,000 a month. For us, in a community mental health nonprofit agency in North Central Arkansas, that was a big deal. And I don't know that I got a raise out of it, but they were real happy with me during that time frame. So some of the other things, we didn't get enough bandwidth. That's something we did wrong. I mentioned that, the 384. We had 768 in a couple of our sites. When the telemed unit would pop on, the phones would get garbly and the internet would slow down. So just be careful of that sort of thing. The agencies that we used Heritage Communication here in Little Rock, Telequality, which is out of Texas, and the Universal Service Administration Company to help cut our costs. Aside from those three and the telemed equipment that we've gotten from the UAMS BTOP grant, aside from those four entities, no grant money, no services whatsoever other than pulling ourselves up by our bootstraps and saying, this is what we've got to do and we've got to make it work. If we could do all that, anybody with a full IT staff, by the way, 22 counties, there's me and there's a system administrator who sits there and runs our server. That's it. I'd like to hire a couple more people, but they ain't gonna let us. But that's it. And so if we can do it on a shoestring budget, agencies who have a full IT staff, who have resources, who have time to go through and coordinate with a Polycom or Tandberg or whoever, service agency, those folks, they can really help you out. On top of all that, you've got all the free services that are available on the internet. If you learn the terminology and Google, most of what you would hire a consultant to do, you can do on your own. Any questions?
Any questions for Brian? I've got one, but I was going to just kind of open it up to the room.
I talk really fast, so it's the Yankee.